Para no retrasarnos mucho en el programa, porque ya vamos unos minutos de retraso respecto a la ponencia anterior y no me gustaría alargar mucho para las venideras y que lleguemos bien en el programa y a la comida. Si les parece, vamos a dar comienzo a esta conferencia. Para mí es un placer poder presentar y moderar la sesión del doctor Randall Walcott. El doctor Walcott es el fundador del Centro Regional Suroeste del Cuidado de Heridas, el Southwest Regional Wound Care Center, en Lubbock, en Texas, en Estados Unidos. Este centro es un centro de referencia allí, es un centro que está especializado en el cuidado de heridas basado en el biofilm y ofrece diferentes alternativas y diferentes disciplinas de tratamiento que incluyen desde desbridamiento, procedimientos venosos, tratamiento con oxígeno hiperbárico, terapia intravenosa, injertos y cualquiera de las terapias que ustedes puedan imaginar. El centro dispone además de la última tecnología en diagnóstico molecular, microbiológico, y también tiene lo que ellos llaman medicina terapéutica, que incluye tratamientos customizados o adaptados a la carta, a la persona que va a ser tratada. Sobre todo se dedican a desarrollar geles tópicos con diferentes productos, como les va a explicar el doctor Walcott. El doctor Walcott es especialista en heridas, tiene una certificación por la Academia de Tratamiento de Heridas en Estados Unidos y tiene más de 20 años de experiencia en este campo. Ha sido ponente en muchas conferencias en su país y fuera de él. Es un apasionado de la curación de las heridas y de la educación de profesionales sanitarios, sobre todo en esta nueva y excitante información, este nuevo paradigma, que para él es de vital importancia y de mucha relevancia en lo que concierne a los biofilms y la cicatrización de las heridas. Yo, sin más, le doy paso. Thank you.
So much. Okay, y'all can hear me. All right, this is extremely exciting for me, so it's very important that some of you smile. Okay, that's going to be important, okay? Here are my objectives up here, and I do have one conflict of interest. I am a part owner of a diagnostic laboratory, a DNA diagnostic laboratory called Pathogenius. And well, let me just talk about it for a second. NASA came to our laboratory to make sure that there was no bacteria on the Mars rover before they sent it up to Mars. And, you know, that's really cool, and that gave us a lot of credibility and everything. But our scientists started thinking, you know, why was it so important that there was no bacteria on the Mars rover before it went up to Mars? Well, then we found out that, you know, Martians don't like bacteria. You know, ever since that movie, War of the Worlds, they haven't liked it very much. Oh, see, this is not real, okay? That's Photoshopped. And a lot of the studies and a lot of the stuff that you'll see on biofilm is Photoshopped. It's made up, okay? So what I'm going to try to do is I'm going to try to give you mainstream articles and mainstream information, okay, on what biofilm is and how it impacts wounds. Well, let's start with what we know. All of us in this room believe that there's bacteria in wounds. Okay, there's bacteria there. The question is, what does it mean? Well, we think it means something because 70% of the time when we see a wound, we give antibiotics for that. Okay, so you believe that the bacteria matter. We behave that way. And then why do we do that? Well, because occasionally we get a wound like this, and this is MRSA, and this is osteomyelitis, this is the end of a stump, this is a BKA that dehisced and went bad. And so we treat the bacteria here, and it gets better. And that's when I knew that bacteria makes a difference in the wounds that we treat. Okay? The problem is when you go to the literature and you have a wound, what we find is and this is Phil Bowler's work out of England, what Phil did was he reviewed several articles, and what he found was that if you get a culture, okay, and 3 of these articles were randomized controlled trials, if you get a culture to treat the wound, to make it better, it doesn't help at all. And that's held up across every study. Cultures don't matter. Ooh, well, that's kind of saying the bacteria doesn't matter. And then a Cochrane study by O'Mara, what she found, well, her conclusion was she cannot recommend that we give antibiotics to patients with venous leg ulcers. Okay, so what she's saying is if we treat those venous leg ulcers with antibiotics, it doesn't make any difference. It does not make them better. And here's the big one. Howell Jones came out in the last 2 paragraphs of his paper, and what he's saying is, hey, there's a lot of wounds. And we give a lot of antibiotics for those patients with wounds. It's not making any difference in their outcome, but it's really driving resistance. So you sitting here in the audience, we're the reason that all that bad drug resistance is happening out there in the world. That's what they're saying. That's what the literature's saying. So which is it? Does the bacteria make a difference in why the wounds don't heal, or doesn't it? So let's start at the beginning. Okay, we know there's microorganisms there. We believe that. Now, those microorganisms can do something good. They can be like commensals. They can help us out. And it would be like, our normal flora. The problem is, what's the normal flora of bone or of tendon or of muscle? You know, there is no normal flora. There are no commensals in wounds, so we can rule that out. So the bacteria is there. Maybe it's a contaminant. Now, like this little guy right here, he's not hurting the wound. He's not helping the wound. Is that bacteria important? No, that's a contaminant, and we know we know what contaminants are. Or is it something like this? Now, this is a study we did back in 2007, reported in 2008. And basically, this is bacteria stuck onto the surface of the wound. So that's what extracellular matrix looks like. This is the extracellular matrix in this chronic wound. And on that is stuck rods and cocci and all this goo, these fibers are holding it on. And so that is on the wound. Now, we're not saying that's infection or not infection. The question becomes can that be doing something negative to the wound? Could this stuff right here, called biofilm, can that cause the wound not to behave right or to make it behave like a chronic wound? Well, the quick answer is yeah, that can happen. Okay, in fact, that does happen. Now, this is work from over a decade ago, so it's very old. This is Costerton, the father of biofilm, the guy that discovered this biofilm stuff, and his cohort, Stewart. And what they found was in cystic fibrosis that this is what happens. And the principle this is a little bit of a leap, but the principle we're saying here is that a biofilm infection in one area of the body, the lung, the principles can translate to another area of the body called the skin. All right? So basically what they're showing is that planktonic single-cell bacteria can attach. Once they attach, they become biofilm. Attachment means biofilm. And that's well vetted, and everybody agrees on that. What's supposed to happen is white blood cells or antibodies, or if maybe you have some antibiotics around, they are supposed to kill these individual cells because they're very susceptible to those things. But if our immune system is messed up, if we're diabetic, if we have poor perfusion, if we have pressure issues, if we have those things going on, maybe our immune system is slow, and within just 5 to 15 minutes, the bacteria attaches, and it expresses a lot of different proteins. Now, this is like going from a caterpillar to a butterfly. It's a radical change. Now, it's still Staph aureus or whatever bacteria. It's still Staph aureus here and here, but it's radically different. Just like a butterfly and a caterpillar are genetically identical, but they're quite different in the way you treat them and the way they look and the way they act. And so this is a new strategy for the bacteria, and it's called biofilm. Now, this is single cell. This is multiple cells. And in fact, in that last picture you saw, it's multiple species. Lots of different kinds of bacteria get together. They form this. Now, what's happening? They secrete this goo around themselves, the webbing that you saw in the last picture. And antibodies can't penetrate, white blood cells can't penetrate, and now it's outside of host control. Now something very magic happens. hundreds of different little molecules get passed between the cells. This is called quorum sensing. So quorum sensing takes place. The bacteria rises up off the surface. It forms a three-dimensional community. It's got substance to it. And these take on different jobs inside the matrix. And then we get to this side. And this is a very important side that nobody ever really looked at before. How does the bacteria feed itself? Well, these guys, they kill cells and they eat those cells. Over here, if this is to degrade or to eat this tissue, if it puts out proteases and it takes up that collagen and that fibronectin and those linear proteins it's attached to, well, it's going to be lost. It'll lose its foothold and it'll be lost to the environment. It won't be successful if it does that. It has to get nutrition in a separate way. And over here, what we find is it upregulates inflammation. And that's what we see in wounds. This intentionally upregulates pro-inflammatory cytokines, the IL-1s, the IL-8s, IL-6, tumor necrosis factor alpha, gamma interferon, all those things that you've heard of. And it also increases neutrophils and macrophages. So it brings in the cells. And that's what we see in cystic fibrosis. Well, that's what we see in chronic sinus infection. Oh, that's what we see in chronic wounds. That is the mechanism by which biofilm feeds itself in a host or a chronic infection inside of a human. And that fits for wounds. So the concept here is that there's a medical biofilm. This is biofilm that causes medical disease. So if we look at all these diseases as a single entity, diseases caused by biofilm, and that's what Patel and Del Pozo, this is out of Mayo Clinic, and that's what they're trying to show with this diagram. Every tissue of the body can suffer from a chronic infection or a biofilm infection. And you know the difference. A chronic infection waxes and wanes, and we call it chronic because it doesn't go away. You treat it with antibiotics, you treat it with things, it gets better for a little bit, but then it comes right back. And that's chronic. An acute infection, that's strep throat, that's cellulitis, that's something you give an acute UTI. You give 1 to 3 to 10 days of antibiotics, it goes away and it's completely gone forever. That's an acute infection. That's different. That's the single cells. That's what you learned about in microbiology. The chronic infections are driven by biofilm. And it's sinus, it's COPD, it's ventilator-acquired pneumonia, it's cystic fibrosis, it's implanted medical devices. Any stone in the body, kidney stone, gallstone, any stones, that's biofilm. Heart valves, endocarditis, and wounds. Now, every discipline deals with their chronic infections. None of us talk to each other, okay? But all disciplines have come to the same way to manage their infections, these chronic infections. And you know what that is, right? How do we manage chronic sinus? Antibiotics, and it gets better, and then we give some more antibiotics, and then finally it gets so bad, what do? Well, we strip the sinuses. Okay, so we do surgery. Heart valve. We treat episodically until it's degraded so much it doesn't work anymore, and then what do? We replace it. Infected metal, we take it out. Infected catheter, we take it out. Gallstones, we take them out. Legs, we take them off. Okay? I'm not here to moralize. I'm not trying to say are doctors good or bad when they cut things off or cut things out. The question for the group here is that the way you want to manage chronic infections? If it's not, let's look at biofilm and see if we can come up with some things. Let's look at two things. This is a 10-year-old model. Is it real? Let's see if we have some. We don't want to Photoshop stuff in. We don't want to make up data. So what we want to look at is, let's look at the attachment side. I've got a really good article that illustrates this because it's a fun one. And then let's look at the other side. Quorum sensing, over 10,000 articles on quorum sensing last year. Okay, 10,000 articles. And one of the questions I'll get an email from you guys is biofilm real? 10,000 articles on quorum sensing. Biofilm is real. Lots of money, lots of research is spent on this phenomenon called biofilm, the way bacteria live as a community. All right, so we're going to look at those two ends, and we're going to look at the molecular underpinnings. I love this one. This is an article by Torres, and basically he went into this experiment to find out if when wild-type Staph aureus, when it encounters heme, when it encounters an internal host environment, okay, so when it sees blood in the water, how is it going to respond? And his premise was it's going to upregulate virulence factors. You're going to see a lot of these virulence factors thrown off into the environment because we know what staph does. Staph goes in and it kills things, okay? It's the marine of bacteria, you know. It doesn't take prisoners. It just goes in and kills. And that's what he expected. So he mapped out the pathways. He saw that this heme pathway, this heme sensing pathway impacted on this heme regulatory transport. I know this bogs down, but I mean, this is good stuff, okay? So I'm sorry if it's too technical. So it senses the heme comes in, it impacts on this little node here. Now, back in 2007, he didn't know what that meant. But then he knew that this regulatory transport would kick it out. But what it also did was this feeds back onto the virulence factors, and it downregulated the virulence factors. Okay, here's the problem. It can't do that. Okay, and so he reports this, and in his summary, he's saying things like, well, this is paradoxical, and this is surprising, and this is interesting, and he's using words like, I don't get it, but this is what it is. And the letters to the editor coming back and cell host and microbe are saying, this is stupid. That's not what staph does. Okay? This can't be. Those should be upregulated. What they didn't know at that time was this was important. And what also he didn't know was he did the experiment that proved it. So he did a knockout where this was gone, this is gone. All these 4 proteins, they took the genes out that express this whole complex. And so now wild-type Staph aureus, gets rid of this. Now it can't get rid of it. Now we don't have this. This is a biofilm node. This is an operon. When this gene gets stimulated, that complex, what that does is it sets up a whole cascade of biofilm behavior. The biggest thing, and what we're talking about now is it upregulates these little sticky things on the surface called adhesins. And those adhesins latch onto collagen, or they latch onto fibronectin, or the linear proteins that make up the breach, the place that the bacteria has gotten. And so this is directly related to attachment. So when it senses heme, within seconds, it puts these little sticky things out on the cell. So now it can attach. This whole system is geared towards attachment. Once it senses, once it knows that it's inside a host environment. Isn't that cool? All right. What happens if we take out its ability to attach? What if we take that system out? And that's what they did with this knockout. And guess what? There are your virulence factors. What we're doing is forcing this to be a single cell. We're not allowing it to attach and become a biofilm. And so what do we get? We get the virulence factors, we get the abscess, we get the tissue damage, we get the ugly stuff that we see from staph infections. Okay? Isn't that cool? So that's biofilm over here. That's planktonic behavior over here. This is the acute. That's the chronic. Okay? In one experiment. And now we know the molecular basis for that. Another one, the inflammatory, and I won't drive this one home. I spoke after Dr. Diegelman, right after I read this, his article in 2003. It was about 2004. And basically, in his article, he's saying, why are all these neutrophils here? And his basic conclusion was, well, because it's a chronic wound and because they're there. Okay? But what's this up here? What do you think that is? Okay, here's what tissue looks like. That's the cell density of tissue. So that's fibroblasts, and that's what host tissue looks like. This nuclear density is way too tight. That is a biofilm. That biofilm is stuck on this surface, and it puts little roots down into this surface. And guess the explanation for all these neutrophils that he's pointing out in his article is probably this bacteria. Can we prove it? Is there a molecular mechanism? Go back to cystic fibrosis. This is Dr. Hartle. And basically what he shows is that Pseudomonas calls in the neutrophils, makes it so the neutrophils can't leave, but makes it so the neutrophils can't function. It secretes these little things that causes that. The neutrophils stay in the area. They degranulate. They finally die and just break open. And then elastase breaks down the CXCR1 receptor, and you get these fragments. Well, these fragments call in more neutrophils, but they also elevate all those things we talked about. Okay, IL-8, interleukin 1 alpha, all those biomarkers you were talking about earlier, all the biochemistry and all the cellularity that you see in a chronic wound is explained right there. And it's because if it inflames the tissue, now it can feed itself off the plasma that percolates out. Okay? So it's not going to kill tissue and degrade tissue because then it would be lost to the environment. It's going to inflame this tissue, and then the plasma is going to come out, and it's going to feed off that plasma. It's quite ingenious. What do we see clinically? We see exudate. All that stuff that's coming out. Now, some of that stuff that's coming out is edema fluid and stuff like that, but we know what wounds exudate, and that exudate is a biofilm feeding itself. And there's the molecular mechanisms for that. I love this one. This is cool. I saw this on the cover. This is the greatest journal ever, okay? Cell-hosted microbe, okay? And basically what this is showing is two things, okay? All host wound beds have cellular senescence. We've always thought that senescence was due to inflammation, that the inflammation cut receptors and made the cells not work right. Not so, okay? Because here we see E. coli. This is E. coli. It has this little hypodermic needle system in it that it can inject things into the cell. This is a host cell. And this is called a type 3 secretory system. It puts little proteins down into the cell. One of those sets of proteins takes over the cytoskeleton, and it makes a little pedestal, and now it's attached, and it's got a permanent attachment on the cell. Isn't that cool? Okay, so you're seeing two things here. What? You're seeing biofilm. It's attached. Second thing is, that is not a normal cell. That is an abnormal cell. That's all senescence means, okay? In the truest, the most common sense or basic sense of the word. And here is a cell that's been taken over. Some of its function has been taken over by the bacteria. Okay? So you're seeing cellular senescence and biofilm in the same picture. That's pretty cool. I get excited about things like that. All right, so putting it all together, there's this controversy brewing from 2007, and Torres that experiment was one of the things that started it off, and then they get these experiments where a third of them act the way they're supposed to, and 2/3 of them, they're funny. They're not it's just not looking right. The data just is weird, like that Torres article. And so a guy by the name of Kim out of Japan came up with this idea. Okay, so he took over 100 articles where he looked at the down here at the pathways, down here at the molecular or the gene level, the internal level of the cell. And he found out that, and we'll just say E. coli, I don't see it over there, but E. coli in one set of experiments would breach the cell, would cause apoptosis, would cause necrosis of the cell. So it kills the cell. It upregulates its proteases. It causes, it eats that, and then it propagates itself. Now, that's an acute infection. That's what he's showing. And he calls that breaching or an acute infection. And he calls that the normal way that we think of infection. Well, then, about 2/3 of the experiments, the bacteria didn't breach. They attached, just like that previous slide we showed. And they make these little pedestals. They also put proteins in here to block all the apoptotic pathways. They immortalize the cell. They make it so this cell can't release from these junctions. This cell can't migrate. It can't make anything. It can't die. And so now you have a wound bed that's just that pale, senescent wound bed that we see. And here are the molecular mechanisms for that. And he called this a new paradigm of bacterial pathogenesis, a new way that bacteria infects. Okay? There's your molecular underpinnings, your molecular basis for why wounds stay chronic. Okay? There's planktonic or acute infections, or there are the chronic infections caused by biofilm phenotype bacteria. Okay, we got it. Okay, so let's go. So now you're clinicians. Now you got to fix this wound. You got this new information. Which one is in there? Is this planktonic or is this biofilm? Well, the answer is yes, both. Both of them are in there, I guarantee you. So which one are you going to treat for? Well, a prudent clinician is going to treat for the harder one. So if we treat for the biofilm phenotype, we know we're going to clear the planktonic phenotype. It's very easy to kill. You know, one course of antibiotics and it's gone. So we're going to treat for the biofilm phenotype. And what we find out is then we get a wound bed that now we can do our cells, our Apligraph, Dermagraph, we can do Regranex, we can do our proactive things to get this to heal. Because if we did it before, the bacteria would just eat those things up. And then we get the wound healed. So the bile burden becomes a very important barrier. Not the only barrier. Pressure's important, perfusion's important, all those things are important. But listen, when I go into the hospital with my pneumonia, give me the antibiotics. You can treat all my other things, but give me antibiotics. Treat the bacteria. And that's what we're saying in chronic wounds. The bacteria does matter, and we have to treat it appropriately. So one of the nurses, when I was giving this lecture, stood up in her chair, from her chair, and she said, I've been doing wound care for 20 years, and I've never seen biofilm in a wound. What is biofilm? Where is it? Well, what I'd say is slough is the downstream product of biofilm. She told me that this was like a bunny in the garden. You know, this is a nuisance. You know, this isn't really what causes any problem. It just accumulates. It's plasma. It's bacteria. But look, that's like snot. I mean, that looks like it should come out of your nose. And this is waxy. This is totally different. Now, my plasma is the same as your plasma. What would cause the difference in that type of stuff? And it must be the bacteria on the surface. It cannot be host factors that cause that. I need to go to the next slide. Can y'all do that? There we go. So this is debridement.
Hasta la vista, baby.
That was Spanish. Hasta la vista. Okay. All right. But when you debride, you don't take away all the bacteria. There's billions of bacteria. We leave little fragments of bacteria all around when we take that down off the wound. Okay? So here, the fragments will reattach. Once they reattach, they become metabolically active. They start growing until they coalesce or they gather together. Once they form that microcolony, now they quorum sense. Hundreds of different quorum sensing molecules, causes them to rise up off the surface. Within 8 to 12 hours, it's coming up. Within 24 hours, you have early biofilm. And if within 3 days, you have that. Okay? So how are we ever going to defeat that? Okay? So, all right. Thank you. So that, now you understand completely what we're up against, okay? But the very thing that gives it that power, okay, that's very powerful to reconstitute itself and to come back from total annihilation in just 24 hours. So the very thing that gives it that power, I need to go to the next slide, is what is its Achilles heel. This is also what makes it vulnerable. This is what allows us to intervene. And we did a study, and we did it in 4 different models to prove that it was true. So we did it this is at CBE, and what we found was once we disrupt and we get those fragments are susceptible to gentamicin. This is Pseudomonas that we were looking at, are susceptible to gentamicin for about 24 hours, and then those fragments coalesce, and now it's a biofilm again. Okay? When we looked at with Greg Schultz down in Florida, we found that the window was about 3 days. And then when we looked in a burn mouse model, we found it took about 4 days before it was resistant to the gentamicin. So you have this period of time that your treating agents that you put on the wound are going to be much more susceptible. Does it work in humans? Well, we took 3 patients, and we took a big wound, and we debrided the entire wound and looked at what we took off, and it was very resistant to antibiotics. And then the next day we went and we debrided an area that we just debrided the day before, so 24-hour-old biofilm, and now it's 4 log to 6 log more sensitive to the antibiotic. We did the same thing on day 2. Again, on 2 of the 3 patients, very sensitive to the antibiotic. By day 3, the window closes. And that's real. And that's what you see in biofilm. You see that when you treat biofilm in dental water lines, when you treat it in the environment. So this is a property of biofilm. So basically, when you debride, you're setting that biofilm up to be more impacted by your treatment. Now, okay, I didn't know. In America, these are bad habits. I didn't know if they were bad habits over here. But that's the only slide I had. All right, so diagnose then treat. That's the first principle of medicine. We treat in wound care by trial and error, okay? And that's not acceptable anymore. And you saw that Don was working on biomarkers, things that we could diagnose what was happening from a pressure arena. We need to diagnose what's happening with the bacteria. The time where we try this treatment for a couple weeks and that doesn't work, then we try this treatment for a couple weeks. We need to get out of that era of medicine. And the only way we do that is if we demand from our reps and our companies and from the brainiac people out there, we tell them we need the diagnostic tools, okay? And so that's what we do. The reason we don't diagnose is, going back to that earlier slide, is cultures. Cultures don't matter. Well, they're 130 years old. It's been over 130 years since that developed. And cultures are predicated on finding certain pathogens over other pathogens. So you're using blood agar and tryptic soy agar. The reason you're using those is because the microbiologists decided that strep and staph and gram-positive aerobic bacteria are very important. And they are. I mean, they're important, no doubt about it. But they're not the only things that are out there. When we look with DNA methods, the gram-positive aerobes are there. But look at all these anaerobes that are there, and look at all these facultative anaerobes that are there. There's a huge, robust microbial community that's setting on the wound, and we're only diagnosing the very tip of the iceberg. And it's not helping us in our management strategies. So that's been the liability of the culture. It's not that it's lying to us. It's just giving such a vague picture. It doesn't matter in our outcomes. Well, why did we switch? Why did we choose molecular methods? And why did we choose the ones that we did? Well, the microbiome project changed everything. It developed new tools. See, these guys went to the companies and they went to the PhDs and they said, look, cultures aren't going to tell us how to get there. We need different tools. So what they looked at was PCR. And they looked at whole genome survey, where you just take all the genes that are in the sample and you look at all of them, you compare them to a table and say, oh, these things are in there. The problem with whole genome survey was it's pretty good. It's not quantitative. And we needed to know how much of each one was there. And pyrosequencing, these gray bars right here, worked out the best. They correlated the best, and they had the least amount of variability. So they did all these statistics, which I couldn't even begin to tell you what they mean. I had a statistician sit down and talk me through this, and I was dumber than when he started. I mean, these are complex statistics. But at the end of the day, what this says is that our pyrosequencing, are taking a small part of the DNA of the bacteria, sequencing it, comparing it to a database, that's the best way to identify what's there, but also the best way to quantitate what's there. And you'll see why that's important in just a second. The day before I get on the plane, this comes out in my email, so I grab it real quick and I put it on when I was traveling over the ocean, okay? And basically what it says is universal 16S PCR. Okay, and you'll see why that's important. That basically what you're doing is you're sending in a primer and asking in this sample, is there any bacteria? I don't care what kind of bacteria, just is there any bacteria and how much is there? Well, that's an important thing. And the other thing they're talking about is plus sequencing. So they add those together. Well, here's a study of 723 patients with pleural effusions. Cultures were negative a lot. They would do this 16S PCR. They'd find all this bacteria in their pleural effusions. They would sequence it, and they would find out what was there. Isn't that cool? Okay, we've been doing that for over 2.5 years. Okay, but this is new for them. Then there's all these experiments on what's the best way to sequence. Do you sequence the entire 16S region in the bacteria, or do you do two small base pair, two small segments of it? Y'all don't need to get into this. All you need to know is this is a whole field of medical science, and what has come down to be the big hot topic is what you're going to learn about today. Very, very cursory, we're going to talk about it. Okay, so what I'm hoping for, what I hope that you'll see is this isn't going to get it. Now, that's something we can touch. That's something we can feel, we can smell. This guy doing this, he can look at those colonies. He can tell you what that is. By the colony morphology, he can say, oh, that's staph, that's Pseudomonas. You know, he can see that, and they're very versed at that, okay? And what we're talking about is coming over here, doing this very elaborate function. It takes 24 hours to take the DNA out of the sample, get rid of the host DNA, get the bacterial DNA, and then that one small segment, that 16S gene, sequence it and compare it to a database, and that all takes about 48 hours. And I'm going to ask you I'm going to say that's better, and you're going to like that better. And you're going to go, well, I know this. This is scary. You know, this seems like black magic, okay? But I think as we get used to it, we'll know better. This is just a head-to-head study. This was accepted last week by BMC Infectious Disease. And basically what we did was we took 50 wounds, just 50 consecutive people that came in. We mixed up what we took off. We sent half of it for culture and half of it for that test with 16S, PCR, and with sequencing. So this is the sequencing data. And my bias was that what we were going to see is cultures were going to find the things that were dominant. If it was 80% Pseudomonas is going to show up in the culture. If it was 80% staph, it's going to show up in the culture. Right? That was my bias. I really believed that was true. And then I thought it was just missing the other things. Nothing could be further from the truth. Only 48% of the time did it find a dominant bug, something that was in there over 10% of the time. Okay, not even half the time did it find the big thing that was in there. 33% of the time, it found things that weren't there or were there in less than 1%. You know, 1,000 times less than the main thing, and that's what it's reporting out to you. Okay, so if that is the gold standard. Now, if we say that the molecular is the gold standard, well, it found 552 things, 10 things per sample, per wound sample that we sent in, whereas the culture only found 2 things per sample. Okay, so this is a much more robust picture. It gives you a more complete picture, and it's quantitative. When you get the answer back over here that it's Staph aureus, you don't know if it's 1% or 100%. You don't know if it's a big thing or not a big thing. So this gives 2 pieces of information that this can never give, and that's quantitation. So this is sequencing. Not going to go into this. Okay, I just wanted you to see the machine. It's just fascinating. It's a black box. When you get into how this is done, there's a movie on Roche's website. You all can understand it. There's one in Spanish. There's one in German. There's one in French. Okay, so whatever language, go look at it. I mean, it's something that you truly can understand. It sounds hard. It gets hard when you take what this machine finds and you run it through the computer. But this is not that difficult to understand. And it's comprehensive. It will tell you 98% of all bacteria. It will tell you 98% of all fungus that's in there. It will tell you about 70% of archaea. It will not tell you anything about viruses that are in there. And yeah, all those things are in wounds. They're all in wounds. Wounds are way more complex than what we thought. All right, so this was the very first one I got back. We sent it in, and this is what it told me was in there. It told me there were 64 things in the wound. And now how would you begin to treat something like that? So we'll talk about that for just a second. What the culture told us was that it was Staph aureus. So is Staph aureus, and then there's a MEC cassette over here. So this is MRSA. That's what the culture told us it was MRSA. But then what do you do with all these other things? And then you start looking at it, and it dawns on you pretty quick This isn't a bunch of individual bacteria. This is a single entity called a biofilm that just happens to have these bacteria that combine together to make it. So this is the current report. We tried to simplify it so you don't see all that stuff. Okay, when you get down to 1% and less, it just gets too complex. So what we do is we do a PCR and report that over here, and it gives us an absolute amount of bacteria. So that's 10 to the 7th bacteria. That's a big deal. That's a lot of bacteria. And this is, quote, a non-infected venous leg ulcer. Okay? So there's a lot of bacteria on the surface in that goo that's on the surface of the wound. And then we had some other primers, and we found other things in there. We take it to sequencing, and 48 hours later we find this, and we find what we see on PCR, 99% of the time we see it with sequencing. So it's a good check, okay? But there are differences, so it's not always one-to-one. And what we find is there's this. Now, instead of breaking it up into individual bacteria, what you need to understand is this is unique. Not just the types of bacteria, but their percentages make this different from anybody else's biofilm. So when you go to treat this truly has to be personalized treatment. And what we would say here is, we use a personalized gel. I have no financial interest in this laboratory. I like the guys that run the laboratory. We send the report to them. They formulate the gel. They send the gel to us, and we put it on the wound, and the wounds get better. Okay? Now, there's usually 2 to 3 to 4 treating agents in there, and there's anti-biofilm agents in there, and there's the special gel that does it. The pushback that I get on this is, why do you treat this way? Why, we've heard triple antibiotic ointments drive resistance and can cause people to get allergies. The point, the reality is that if you want to get drug resistance, you give systemic antibiotics. Because when we give topical, we're given 200 and 300 times MIC. So that's the way not to get resistance, is topical. But here's the best argument. ENT has used topicals for treating external ear infections for 40 years now, and they have data on that. So Pseudomonas against colistin 40 years ago was about 99% sensitive to colistin. And now, 40 years later, they reran the study, and it's even more sensitive. It's 99-point-something sensitive. So it has not driven resistance. In fact, the guy that told me this statement, Dr. Poole, said that if one of my colleagues started treating external ear infections with systemic antibiotics, he'd try to see that he'd lose his license, because that's so stupid. You've got the treatment of choice. It's well vetted. The literature is clear. And that's where we want to go with topical treatment of wounds. The reason topical treatments didn't work was because they were not targeted to the bacteria that were actually present. Now that we know what we're dealing with, and now that we can reevaluate and see if we're getting it, topical antibiotics, I think, will have a real role in this. And I need you to advance that one, too. Can you advance the slide? Next slide. There we go. So now we're going to manage. Okay. What the point of this slide is everything you need to know about biofilm, you already know. Okay. When you're managing your teeth, when you're managing your tub, when you're managing your toilet, don't overthink it. Just use the principles that you already know. Get rid of it. You don't really need to use your head. And then we want to start doing things. The big question I get is osteo. What if there's osteo involved? Okay. Now this is Wyman. He's a homeless man in Lubbock. He can't go to our hospitals because he's done things at our hospitals that they won't let him in. Okay, but he's got osteo. But is anybody here thinking we should cut his head off? No. Okay, we'll leave his head on. But the reason we cut legs off is because they have osteo. Okay, all you have to do is take it down to good, solid bone. And to bleeding bone, and then it'll granulate over and it'll heal up. And the same is true in a diabetic foot ulcer. The same is true in all the other wounds that we treat. If you get osteo, the reason we cut legs off is because it's easy to cut legs off. We don't cut butts off. We don't cut heads off. So, I need you to advance that one. There's going to be a lot of movies, so you'll have to get these. All right, so this is biofilm-based wound care in a nutshell. Basically, it's going to be frequent debridement. A lot of pushback from that. I feel empowered. I don't know what level you're at in your medicine, but the more you touch that wound, the more you disrupt the biofilm, the better. Now, you saw those bubbles there? This is a guy from Muleshoe, Texas, and he has gas gangrene. That's what those bubbles are. And they told him he would die if he didn't have his leg off. And basically he said, I want to try. Okay? He wouldn't let him. So here we are in the clinic. They wouldn't let him stay in the hospital. And we're going to debride frequently. We're going to use selective biocides. We're going to do things that kill bacteria but don't kill the host. Now, if you just use one of these, the bacteria is going to change, and it's not going to be sensitive to it for maybe a couple weeks or so. So we rotate through those. We do it dynamically. We're going to use antibiotics personalized, and when the wound slows down, we're going to change our antibiotics to fit the bacteria that are now there. Now look what's happened, okay? See the skin edges, how they're all down? What is this stuff right here? You know, that's connective tissue. Okay, it didn't grow there. What's happening now is the neutrophils aren't commandeered anymore. They're not taken over by the biofilm. So now they're cutting that tissue, and then the myofibroblasts are pushing that out to where you can get to it. Now this is 1 week later. We just took bone out of there. Okay, and there's bone again. Now, how did the bone get there? It's because now the wound's healing itself. Things are working. The neutrophils are cutting things. The myofibroblasts are contracting. The wound's contracting, and it gets down to where we can do it. Now, this is not a great foot. This is a horrible Charcot foot. Okay? But after about 20 weeks, we get to here, and he goes into the hospital, and he gets a skin graft. It took everywhere but these two places. So, I mean, he saved his foot. He's in a crow boot, and he can get on his tractor, and he can do his stuff. And I need you to advance that slide. Next slide. Okay, so now that's biofilm-based wound care. That's what we saw. Now what we're going to do is we're going to start combining it with our proactive things. I think this is pretty cool. Basically, when we do that same stuff that we showed in the previous slide, frequent debridement, personalized gels, rotate through our selective biocides, what we find is we heal wounds faster, but then when we combine it with cells, what we get is about 20% better healing in 3 months and about 20% better healing in 6 months. Over if we just put cells on alone. Basically what this shows is it makes your proactive things work better. Your Regranax, anything that you're going to put on there to help the wound or to stimulate it to heal, bacteria interferes with that. If you can suppress the biofilm enough, those therapies work better. What does that look like clinically? This is a lady that had she's on Coumadin. She's got multiple illnesses. They said she was too sick to go in and get this off. She fell on her knee, and this is a huge hematoma. It's been there for 3 months. And so she doesn't want it there anymore. So we take it off, and that's how deep down into her leg it goes. And so we go ahead and we put Apligraf on about 3 weeks later. That's what Apligraf looks like. And basically, we're doing a crossover study. We're going to treat this area, and then we're going to treat this area and see which one heals first. And if this heals first, that means that the graft had some effect on the wound. Well, this is a week later, and I just left that in to show you. The graft doesn't degrade. It doesn't turn into goo like we normally see with the graft. And it's having a good effect on the wound. 2 weeks later, we take it off. We leave it on for 2 weeks. And here's this glistening base that we always see. Over here, it's more rough. You don't see this clear, glistening goo on it. We graft the other side because it's been 2 weeks. Okay, so now this is 2 weeks after we started. 2 weeks after we started with this, and what we find is that's healed, and there's that glistening goo. So basically, the Apligraf had to have some effect on the healing of the wound because the side that we treated first healed faster than the side we treated second. But it also shows that if we control the bacteria, the graft works a lot better. And this will be our last case. our last series. This is what we used to see back in 2004. And what we found, this is a social worker, and he came in with this foot. And what he said is, if you cut my leg off, I know I'm going to die. I'd rather die with my leg on. And I said, well, before you die, let's just try to heal the wound. And basically what we're saying is these people don't get septic and die. Okay, there's plenty of time to try to heal this foot. There's no question he has osteo. He's got some toes sticking out where they don't belong, and there's exposed bone. This is 3 weeks later, and it cleans up pretty good, and that's 5 months, and that's 9 months. So that's what we used to see back in 2004. If we got aggressive with the wound, we could heal these up in about 9 months. But again, back in 2004, we're doing biofilm strategies, the best we had with the tools we had then. Here's what happens now. This is a patient, he's a 43-year-old construction worker, got some concrete on the top of his foot. He goes to the emergency room, and he's got a sack full of pus in his foot. And they take him to the operating room, and they find 2 areas of osteo in his foot. And so what they do is they wake him up in the recovery room, and they say, you know, you have osteo, so your leg's going to have to be cut off. Well, he's a construction worker. Okay, so he used construction worker language, and he told him, no, thank you. Okay, but he used lots of other words. Okay, so he cussed him out, and so they put him in a room, and eventually he realized that they weren't going to treat his leg. So he walked out of the hospital with this, and he came to our clinic on this day, and he said, I just want to try. Okay, now in 2009, we have the diagnostics. We have the personalized gels, okay? And so this is 4 weeks later, and this is 8 weeks later. We let him go back to work, and 12 weeks later, we said he was healed, okay? So the question, that surprised me to no end. But the reason it's surprising is because we know the way that chronic wounds behave. They take a lot longer than that to heal. But if you collapse the biofilm, it's no longer a chronic wound. Now it can behave as an acute wound. And that's what this data shows. So we did groups of 500 people, and what we found is if we did standard of care, we got numbers that met like the national average. If we did the DNA diagnostics with the targeted personalized gels, we got much better healing. But look at this. Once we got past 90 days, we only gained about 1% to 2% a month. And that's about what you gain down here. So basically, all of these improved outcomes, all these healed wounds in the first 30 to 60 days was because biofilm was the main reason that it wasn't healing. So it's not that we still get the same 80% healing rate, but we get it out here at 9 and 10 and 12 months. So by managing the biofilms, you can heal more wounds and you can heal them faster. So that's the biofilm surprise. Biofilm is not a bunny in the garden. The slough that's on the wound is the problem. Okay, that is your main problem. There are 2 ways that bacteria infect. Okay, they can infect the way you were taught, but they can also infect as a community, as a biofilm. Molecular methods are superior to culture methods in diagnosing biofilm infections. And then if we can couple that with targeted personalized therapy, we get better outcomes. Thank you. I went past, sorry.
Thank you very much, Randy.
Thank you.
Estamos en el tiempo, más o menos, hemos empezado con 10 minutos de retraso. Sí, perdón, que no había dado al botón de el micrófono. Estaba diciendo que estamos fuera de tiempo, pero también hemos empezado aproximadamente con 10 minutos de retraso. Y bueno, agradecer al doctor Walcott su interesante presentación. Creo que nos aporta datos muy novedosos, algunos quizá demasiado complejos en su presentación, pero que creo que nos puede abrir un poco la mente hacia una nueva perspectiva, hacia un nuevo paradigma, como él comentaba en alguna de sus diapositivas. Me gustaría saber si hay alguna pregunta. Ya veo que hay una mano levantada en el centro de la sala con una señora con la camisa azul. Y bueno, voy a dar 2 preguntas más por el tiempo en el que estamos. Te tomo nota. Ya tenemos las 3 preguntas.
La pregunta es en cuanto a algún apósito tópico como es el cadexómero de yodo o la plata. ¿Qué resultados tienen ustedes en el biofilm? Porque hasta en la actualidad, bueno, en México es como se están haciendo las curas en los pacientes con biofilm.
Okay. As far as dental plaque topical treatments, we are working with several oral surgeons and physician or dentists across the country. The problem is the complexity goes up an order of magnitude. They don't have 10 things; they have 100 things, and so it makes it much more complex for them to treat. So they're going more towards broad spectrum types of treatments. So they're going to high dose biocides. So they're using and a lot of these things are proprietary, but they'd be using things like full strength peroxide, 16% peroxide, things like that to overwhelm, because targeted treatment with antibiotics is too difficult. These are bugs that they don't even know. They're names that haven't been studied in the laboratory. There's synergies they don't know. So they've taken the pathway of not using antibiotics, but using very high-dose antiseptics or biocides. Did that answer?
Gracias. Aquí debajo tenemos... Aquí en...
Bueno, estoy encantada de tenerle y haberle oído hoy porque le conozco por los distintos artículos que le he leído. Y también estoy entusiasmada con el biofilm. Sí, será por los quebraderos de cabeza que me da a la hora de abordar las heridas. Se ha referido usted a una serie de geles que encargan a la industria. No sé si en ellos alguno de sus componentes son el xilitol o la lactoferrina, que ya le había leído decir que tenían efectos beneficiosos con respecto al biofilm.
Yes. And everybody heard that question. Do I need to repeat the question? Do I need to repeat it? The question is the gels. Is there lactoferrin or other ingredients in there besides antibiotics? And the answer is yes. John Kennedy and Curtis Jones, it's a compounding pharmacy that I really don't even know the name of, Southeast something. And these guys have about 15 anti-biofilm agents. We gave them 3. Lactoferrin was one, xylitol was one. We use gallium. And an anti-biofilm agent are just things that break down biofilm defenses, break down that goo, and it makes antibiotics more effective. Now, there are quorum sensing inhibitors, and we're working with Naomi Balaban and a few others to get staph quorum sensing inhibitors, and those are coming. But if you can, and these are just very low dose things that they put in the gels along with the antibiotics that break down the defenses so the antibiotics work better. So anti-biofilm agents are real, and someday we hope that they will become the main thing. But right now, we have antibiotics, and they're going to have to do most of the work for us until we can get, more specific. A group is now starting with microRNA silencing RNA treatments to block the effect of the bacteria causing the senescence. They're doing that in animal models, and that looks real promising. So it's going to get real high tech, but right now we understand antibiotics. We understand that you can put things in to make the antibiotics work better, and that's what the gels are centered around. They don't, you know, if you email me, I can get you in contact with them. They'll get you in contact with people over here. They can't, it's a compounding pharmacy. They can't work over in Europe, but they could sure work with somebody over here to get this done for you guys. So, any other?
Sí, está aquí de abajo.
Buenos días, enhorabuena, felicidades, me ha encantado su comunicado, su exposición. Y lo único, bueno, parte de mi pregunta ya ha sido respondida. Quería preguntarle a ver si en España, en algún sitio, se realizaba pues esta PCR, ¿no?, que ha comentado usted. Nosotros lo que hacemos es hacer y a ver si aquí podíamos conseguir ese gel individualizado. Ya creo que no. Y luego otra pregunta es, nosotros lo que hacemos en estos casos es hacer una biopsia bacteriológica cuantitativa, que no sé hasta qué punto también, es mejor que el cultivo, pero tampoco tenemos luego la posibilidad del gel individualizado. Gracias.
¿Pueden activar su micro inalámbrico? Está, ok.
Okay. So the question is where do you get the diagnostic testing? What you have to do is you have to go to your universities, and you got to go to the guys in the, you know, like Jose. You got to go to the guys that are up in your wound care communities, and you got to say, we want this stuff. And then they'll start talking. Basically, I found my guy out in a cotton field, and he was testing the bacteria in cow guts, okay? And I said, can you do that for wounds? And so he was a PhD at Texas Tech University, and we took his technology and we turned it on to wounds. And it's that, I mean, if you don't ask, they're not going to come to you. They don't know that you need this. So you just start talking, you start emailing people, and you say, I want to do 16S PCR.
A ver, el doctor Walcott lo ha dicho en su presentación. Llevamos 130 años utilizando el mismo método de diagnóstico de bacterias, que es el cultivo. La biopsia no es un método de diagnóstico, es un método de recogida de muestra. Lo que se haga luego con la biopsia es lo que va a marcar la diferencia. Yo puedo la biopsia hacer un cultivo, mirarla al microscopio, utilizar técnicas de diagnóstico molecular, etcétera. Entonces, lo que quizá debemos empezar a cambiar es nuestra corriente de pensamiento. Estamos marcando un paradigma que es el que ha venido siendo utilizado desde hace 130 años, que es difícil cambiar hábitos, es lo que está ahí, y lo que tenemos que hacer es intentar demostrar que el otro paradigma también funciona y que además se ajusta mejor a nuestro modelo. Y esto es el trabajo que nos queda ahora, ¿no?, el cambiar de paradigma. No nos queda mucho más tiempo, nos hemos pasado del que nos tocaba y debemos seguir con el programa. Muchas gracias a todos por estar hasta aquí.